There are two different types of bone within the mouth. The first type of bone is cortical bone, and the other type is trabecular or cancellous bone. Now, knowing the difference between these two types of bone is actually very useful when we're taking teeth out, because the type of bone that we're dealing with will sometimes dictate the way that we should be approaching a tooth when we're extracting it. Now, the types of bone basically vary a little bit in terms of their location in the mouth, in terms of the amount of deposition that there is. So the maxilla, for example, will have a little bit more cancellous or trabecular bone, and in the mandible, especially in the posterior, we're going to see a lot more of that cortical bone. Now, if you look here at this picture, basically this is a look at the cancellous bone surrounded by the cortical bone. So the cancellous bone is that inner trabecular bone, the porous looking bone, and the outside shell there is that cortical bone. The cancellous bone is located basically on the interior of the maxilla and the mandible. This is the filler in those jaws. So it's basically surrounding the roots of the teeth, very, very soft. So you'll know it when you see it. If you push on it with your elevator, you can essentially scoop it out or basically crush it down just by pushing on it. Now, very, very soft. It's also kind of good when we're taking teeth out because it's a little bit more forgiving. So when you apply some pressure on a tooth, you're leaning on it, you're helping the bone to expand. What you're expanding is not the cortical bone, you're expanding the cancellous bone or trabecular bone that is surrounding the roots of the teeth. Now, keep in mind there is a thin corticated wall that you'll see even on a PA, that little white line that surrounds the root of the tooth. That is a corticated bit of bone, and you'll feel it too when you're curetting. But a lot of times we run into, beyond that cancellous bone. That's where it is. Cortical bone makes up that hard outer shell of bone that we talked about earlier. Now, it surrounds the cancellous bone, makes up the exterior portion of your maxilla and your mandible. Now, the thickness of the cortical bone varies depending on where you are in the mouth, and that's very important. So let's say that we're in the lower anterior part of the mouth, we're working on these lower anteriors, we're taking one out. You might have maybe about 1.5 millimeters of cortical bone thickness, sometimes even thinner depending on where those roots are positioned. Now, as you move posteriorly in the mandible and you get back into where those lower third molars would be, you can have even up to maybe 3 millimeters of cortical bone back there. So if you've ever seen an oral surgeon take out an impacted third molar and you see them reflecting that flap, you see that shiny white smooth surface, that's the cortical bone that we're looking at. And they're going to cut a trough in there lots of times around the buccal surface of that tooth, which gives them access for their elevator, but more importantly, it removes that cortical bone, which will not flex or bend, allowing and facilitating a path of withdrawal for that tooth. Now, one other thing about cortical bone is that it's also a store of chemicals in your body, specifically calcium. So this is all very interesting, but how does this apply to you? Why do you need to know that there's different types of bone in different areas of the mouth? Well, I got a few reasons, and one of those reasons would be, let's say we're taking out an upper premolar tooth. So that upper premolar is leaning out to the facial aspect of the mouth. The root is tipped in and it's laying squarely against the palatal cortical plate. Now, what's going to happen when you go to apply your typical buccal forces to that tooth is you're going to get very little movement. And the reason is because there's no cancellous bone left in between the tip of that root or that root apex and that cortical bone. So the cortical bone isn't going to expand the same way that the cancellous bone would. So if we continue to apply our forces to that tooth in a buccal direction, we're likely going to break the root of that tooth and we're going to have a more difficult extraction as a result. Now, that's just one example. There's many examples of that. So you need to kind of consider which way are the roots leaning from this tooth. Might they be touching the cortical plate or butted up against it? If they are, you might have to alter the way that you're applying your forces to the tooth. Now, another area that you may need to know this for would be, say, if you're working in the posterior of the mandible. In the posterior of the mandible, like we talked about, as you go farther back, you've got way more buccal cortical plate there, more dense bone along the buccal portion of the teeth than you would on the lingual portion of those teeth. So when you're working at getting a lower molar out, most of your expansion is going to be easier to achieve moving in a lingual direction and delivering in a lingual direction. Now, you should still go lingual and buccal with sustained pressures, but you're going to have an easier time delivering those teeth to the lingual aspect. Now, the other thing to note about this would be if you are approaching a tooth and let's say again you're in the posterior of the mandible there, or maybe you're in an area where someone's got great big tori, so down in the lower premolar region. What's going to happen there? Well, likely with all that cortical bone there, how are we going to be expanding that bone? It's just not going to happen. So we might choose from the onset just to go with our surgical extraction, maybe cut a trough around the tooth, do something to relieve some bone right off the hop, just to get a better mechanical advantage on that tooth and get it out with fewer complications in a quicker amount of time.